We're talking with Diane Sagan from Southern California. Her 50-year journey with her husband Jay, and recently a lot of dynamics came into play as he was diagnosed with Parkinson's back in 2009, and then shortly thereafter, less than 2 years after that, started to develop the psychosis component to this. And it's been a very serious adjustment for her. And I'm also joined on the phone with Dr. Daniel Claassen from Vanderbilt, one of my dear friends, who's a neurologist, deals with Parkinson's, Alzheimer's, Huntington's disease, and just a brilliant guy, but a guy with a heart as big as his intellect, who just loves these folks and their families. And so, Dr. Claassen, are you with us?
Hey, how you doing, Peter? Thanks for the kind words.
Well, you're a kind fella, and sorry for the non-professional intro.
Yeah, I was going to come out with Peter Rosenberger psychosis there a little bit.
That is John Butler.
Well,
Choice cuts, guys. I'm telling you.
Choice cuts from John Butler. Well, Diane, Dr. Claassen, you two can meet together here, but Diane was sharing a little bit of her journey and what has been happening with her and Jay. And now this is the first I've heard of this. Dr. Claassen, you've been dealing with this for some time. Tell me a little bit more about what's going on. What happens here, neurologically speaking? What is happening here with this psychosis?
Yeah, well, I think Parkinson's psychosis probably is under-recognized by a lot of providers, primarily because sometimes patients don't really know that it's happening. So you can think of the word psychosis really to capture a term that basically includes things like visual hallucinations, auditory hallucinations. So most commonly people see things that aren't, so to speak, real. They're not there, but they're real in their consciousness. And what happens is people act on them. So in extreme cases, you can think of some really bad stories that have come in the news recently, where patients have taken out a gun and shot at a hallucination and end up killing a loved one. That's a really extreme case, but one that really captures the severity of how problematic this can be. In Parkinson's disease, really one of the areas of the brain that gets affected is the visual integration system. So how we see things and how we understand what they are and where they are in space, that part of the brain gets messed up, so to speak. And because of that, it's very frequent that patients will have visual hallucinations. And the second part of the brain that also gets affected is the emotional regulation. So when it becomes a real problem is when patients have fear that's associated with those symptoms or concern about those visual hallucinations, wanting to do them harm. And so you can imagine it can be very troubling for a caregiver to look after a patient that has that, because they're having a hard time adjusting to the instantaneous request of a family member who's acting on something that's not real. So it's a big clinical problem.
Well, so Diane, listening to this, I guess it would fall. One of the reasons this thing has not been as noticed as you would think is that it really does fall on the caregiver to probably bring attention to this thing. Is that a fair statement, Diane and Dr. Claassen?
Absolutely. I was thinking about that today, how it's kind of an invisible thing. His friends don't necessarily know he has it until they sit with him for a while, and then it, becomes apparent.
So that's one more burden that a caregiver has to deal with, is all of a sudden we're seeing things now that would not be even diagnosed were we not bringing it to the attention of a physician. So, Dr. Claassen, what would you say to caregivers out there when they're seeing these things? How can they quickly bring this to the attention of the neurologist that's involved or the family physician or whatever, and what are some steps to do? You can't really treat this, I guess, can you?
Yeah, well, there's a lot in that question. Let me first make a comment by saying that every little clinical information that you can give to your doctor is probably important. For instance, there's this one unusual part of Parkinson's disease where patients act out their dreams at night, where they start believing that people are chasing them or there's an animal in the room that's coming after them, and the patient will start screaming and sometimes hit the spouse or jump out of bed, and that's called, it's a fancy name, is REM behavior disorder. But, that's been going on for a while, and it wasn't until patients started saying, is this actually something that we need to take care of, that physicians realized, wait, this may be one of the earliest signs of Parkinson's disease. So I would say the first thing is that every little bit of information helps. And so what I recommend caregivers to do is kind of jot things down on a piece of paper, because when you go see your doctor, maybe you've got 20 minutes, maybe you've got 30 minutes, and that happens fast. And so having that information ready for your doctor is really important, so that they can be alerted to what important therapies may be available for you. The second thing about the treatment is that, yes, it is a difficult thing to treat. There are some very good treatments to help it. They range depending on the severity of symptoms. There are some new treatments coming down the pipeline which actually have a lot of potential to offer help to patients. And so I would say that this is not something that you have to live with. This is something that you and your doctors can treat, and it may be pharmacologic, it may be non-pharmacologic.
Well, we were just talking about that earlier. Diane mentioned that in the prior segment, that she started experiencing that when Jay would start running or trying to hit something in his dreams, and then she was afraid for her own safety on that.
That's right.
And so I think that the lesson from this is, and I've said this for some time, that we caregivers wield a significant amount of authority in this. We're not experts in the science of it necessarily, but we are experts in our loved ones. And it's okay for us to raise our hands and say, hey, I'm noticing these things. And a lot of times we're afraid to do that. We may feel self-conscious about it. We may feel embarrassed for our loved one trying to protect their dignity. But I think you just heard very clearly from Dr. Claassen, it's not only something we should do, it's something we really must do to bring that information to the hands of the medical professionals. And because the loved one can't always see these things. They don't necessarily know what's going on with them, but we as caregivers are watching and observing it and seeing it, and that's our responsibility to wield that authority. Is that a fairly good summary of your thoughts on that?
Yeah, I think you're spot on, and I think you and I have talked before about kind of coming into that doctor-patient relationship and really taking charge over, okay, doctor, here are the main things that I need to go over with you. Let's talk about these. They're on my list before I leave today. Can we make sure we get over them? I think that's really one of the hard areas that, it's a little different. When you're seeing your doctor, sometimes you just expect, all right, we're going to go in, what happens, but taking charge over the things that you want to talk about is really important. The other point I'll make is that it's not just one doctor. In the case of Parkinson's psychosis, we often get our colleagues in psychiatry to come on board. We often get our colleagues in sleep medicine if people are acting out dreams, like was mentioned earlier. So it's a real team approach. And building that team can be sometimes challenging to caregivers because you're starting to juggle a lot of balls, a lot of different doctors involved, a lot of different expertise, and they got to make sure they talk to each other. So that can also be a big challenge for caregivers. Well,
Diane, does that register with you?
That really does, yeah. Jay's seeing a lot of different doctors, and it's interesting. It took me a while to realize I had permission to be a spokesperson for him. HIPAA sort of trains us that, oh, no, none of it is my business, but it is my business because I'm his caregiver and really his advocate. So I go with him to all his appointments and,
I'm almost certain, by the way, that HIPAA was designed by non-caregivers.
Oh, yeah.
I'm just almost certain of that. That has been the source of frustration for me over the many years. And it's, once again, is the glaring inefficiency of people in government. But I understand their intentions were noble. But you're right. It takes, you feel a little bit self-conscious speaking for someone else, don't you?
Absolutely.
But you heard it right here, straight from the doctor. He said, we must do this because we're the only ones that are going to see it. Jay's not going to know if he's acting out in the middle of the night in the middle of his dreams.
No.
And he's not going to know that his family didn't show up and he had a conversation with them in the living room and they were never there. Mm-hmm. But you do, and so these are things we need to write down. And I would say this to all our caregivers, that we need to write these things down, jot them down, and then go in there. One of the things I recommend doing is also just going down with 3 big topics when you deal with your doctor. What are the action steps we want to get out of this meeting? What are the things that we want to accomplish today? Don't go in there and leave things open-ended. I mean, Dr. Claassen, you jump in on that one too, but I'm a big fan of saying, okay, what's the next action step? And the next action step may just be to wait for 6 months, but that's still an action step.
Mm-hmm. Yeah, that's right. I think I think as a physician, when I have a patient that comes in with, hey, these 3 things we want to get over today, that's really helpful for me because I know I get a picture for the last 3 to 4 months. I haven't seen them, but I get a picture of what's going on in the interval time. What are the big issues that are going on in their lives? And sometimes patients actually bring care advocates with them. I don't know if you've had experience with that, Peter, but I know that's an increasing
experience with it. We've got a sponsor for that on our show. And let me give you their number, 615-298-9201. That's one of our sponsors, and they have been for some time because,
that's Care Advocates by Whole Care, right, Peter?
Care Advocates by Whole Care. And I've been doing this with Gracie for a long time, but I don't think people want to try to, the learning curve's pretty steep. Let's get a professional in there. Listen, we're going to have to take a break here, and I know that Dr. Claassen's got to leave. And boy, Daniel, I appreciate you coming on. I really do. You're just such an amazing resource. Diane, you stick around for a little bit longer if you don't mind.
Okay, no problem.
Doc, thank you so much. I'll see you next time.
Yeah, I'll see you on the piano.
All right, this is Peter Rosenberger. We are the nation's #1 show for caregivers, and we're glad you're with us.